I'm aware that most of the audience are neonatologists. This is kind of a bit later on, what happens to them as they get older. And they're all beautifully looked after throughout childhood, and then they come into adult practice and it all tends to go a little bit wrong for them, unfortunately. What do we see? So we see quite a lot of patients with a pre-existing diagnosis. We still see quite a few patients who we diagnose DiGeorge in who don't have a pre-existing diagnosis. And we obviously look after their cardiac conditions, but our role is quite broad in these patients. So we do also pay quite a lot of attention to the non-cardiac manifestations, and we do quite a lot of work with them around pregnancy. You've already heard quite a lot about genetics, but obviously all these patients aren't routinely under genetic teams sort of lifelong. They just go back to them at points in time in their life. So this child on the left obviously grows up to be the adult on the right. And these are the kind of people that we involve in their care, or that are involved in their care. So obviously there's cardiac, and then immunology, GI, endocrinology, ENT, ophthalmology, the various specialties that you've been hearing about. In adulthood, some of the other services become a bit more important. So primary care obviously take a bigger role than in childhood, when most of this will be coordinated really through community paediatrics. But we do quite a lot of coordination with social work, psychiatry and mental health services, and as I've said, reproductive medicine and genetics. I think you've already talked about this, which is the consensus document published by the Max Appeal, which is really good. And in adulthood, in their executive summary, they recommend annual full blood count, calcium, thyroid function tests, height and weight, monitor for autoimmune disease, regular dental care, social work and adult learning disability team input, and coordinated care by a key worker. Well, not very many of them get that, I'm afraid to say. So they should be flagged in primary care to get all of these things done. We do quite a lot of it in cardiology, which is clearly strictly not cardiology, but that may be their only contact. So we do quite a lot of this. So what cardiac conditions do we see? I think you've already talked about some of these, but obviously as they survive through to adult age, the kind of long-term sequelae are quite different to what you see in children. So these are the conditions that are particularly associated with 22q11. So tetralogy, pulmonary atresia VSD, Truncus Arteriosus, interrupted aortic arch, and VSD. So adult tetralogy of Fallot is quite a different kettle of fish to paediatric tetralogy of Fallot, or neonatal tetralogy. So it's quite common. I'm trying to think how many we now have on the books in terms of adult patients in Yorkshire number. It's probably getting on for 1,000 patients. And so this is what the heart looks like. Can you see my pointer? Does that shine up? Yeah. So this is what the heart looks like, obviously in a newborn with tetralogy. So VSD, they haven't really drawn the overriding aorta very nicely on here, but pulmonary stenosis, and here a right to left shunt. So when this is operated on, the VSD is closed and the pulmonary valve is opened up. And what that usually ends up with is a patient with pulmonary regurgitation, so regurgitation on the pulmonary valve, which gives them right atrial and right ventricular stretch, which in turn can lead to arrhythmias and right heart failure. So many of our adult patients undergo pulmonary valve replacement, and that's either transcatheter increasingly or surgical pulmonary valve replacement. And we'll just talk a little bit in a moment about why it's specifically those can raise issues in patients with 22q11. So this is what we see on MRI in an adult tetralogy patient with pulmonary incompetence. So left atrium, left ventricle, right atrium here, and a big dilated right ventricle. So this dilatation of the right heart is what we don't want to see, and that's why we replace the pulmonary valves. And that should, if you do it in time, that should come back to normal or near enough normal. Pulmonary Atresia VSD is another cardiac issue which is related to 22q11. It's less common than tetralogy of Fallot, and the surgery that these patients have is a reconnection of the right ventricle to the pulmonary arteries and augmentation, hopefully, of these horrible little pulmonary arteries in this particular diagram, but often a tube graft from the right ventricle to the pulmonary arteries. And the most common problem in adult life relates to the RVOT to pulmonary artery connection, and it frequently requires re-intervention in adulthood. So again, surgical all transcatheter rehabilitation of the RV to pulmonary artery conduit, and also intervention to the pulmonary arteries. So this is what we can see. This is the aorta, and these are aortopulmonary collateral vessels. So in a patient with complete pulmonary atresia, and sometimes in adults, we end up intervening on these collateral vessels out to the lungs to improve pulmonary blood supply, and that can be done with stents, sometimes cutting balloons, and often areas of the lung in these patients are pulmonary hypertensive. I think you've talked about Truncus Arteriosus, but again, in the adult, it's different to neonatal. So you'll see common arterial trunk here overriding the VSD and sitting above two ventricles, and then your common arterial trunk divides at some point into two-ish great vessels, aorta and then pulmonary artery coming off here, or the branch PAs are different arrangements of the pulmonary arteries. But common issues in adulthood. So in a neonate, this will be repaired with VSD closure, and then the pulmonary artery to RV connection will be reconstructed surgically. So in adulthood, we see quite a lot of problems with the truncal valve, with truncal valve regurgitation, quite often requires valve replacement. We see quite a lot of patients with residual VSDs here, and we have issues with the RV to pulmonary artery conduit and the proximal pulmonary arteries. And virtually all of these will require re-intervention in adult life, again, either surgical or transcatheter or both. And these patients usually require repeated re-intervention. So you can see a theme of what I'm talking about is re-intervention in adult life in all of these conditions. So this is the operation that's been done. This is the tube graft from the RV to the pulmonary artery. And you can see that you've got lots of suture lines in here. You've got a VSD patch. This is the homograft or the conduit which degenerates. And this is where the pulmonary artery has been detached from the aorta. And you can get problems later on with these sites, these surgical sites getting either aneurysms, or you can get narrowing. You can see pulmonary arteries which have disappeared, presumably at the time of the neonatal repair. And then interrupted aortic arch is also one of the commoner things that's seen in 22q. There's loads of different repair methods, and it depends on the original anatomy, but patch aortoplasty, so augmenting the aorta with a patch, interposition grafts, this sliding arch aortoplasty, and then this kind of repair here, which uses part of pericardium to repair the aorta. And obviously these all introduce areas of weakness into the aorta. So in adulthood, we screen for residual aortic arch obstruction, aneurysms at the repair site, and also hypertension. This usually requires MRI assessment and less frequent need for re-intervention than other lesions, but still a reasonable amount of re-intervention, and these are usually transcatheter re-interventions. This is a fairly horrible and extreme example of a patient with an aortic arch repair with a large aneurysm associated with the repair, and that's been treated endovascularly with this pretty enormous stent graft to exclude this aneurysm and also to open up this narrowed segment at the top here. So that's a fairly big intervention which carries quite a lot of morbidity associated with it. So you can see that we do lots of re-intervention, and patients with 22q11 are not immune to that, obviously. There's no particular difference in the pathophysiology of the cardiac lesions and their management to non-22q11 patients. So lots of our patients have re-interventions as well if they're not deleted. But we do have other issues at the time of re-intervention specific to this patient group, which we need to think about. So airway issues in particular, those patients who've had previous ENT surgery and interventions, the anaesthetist need to be aware of that. Patients with immune compromise who have an increased risk of endocarditis. We've certainly seen some pretty nasty endocarditis in patients with DiGeorge syndrome. Often, of course, patients have a degree of learning disability, and that can make their stay in intensive care or on the ward problematic for them, and also quite challenging at times for staff. And there's lots and lots of work that goes into making those ward stays as easy as possible for the patient. So patient passports, we use the hospital learning disabilities team a lot, and obviously family and carer support. There are issues around consent and whether patients have capacity to consent for their own treatment. And then things like other physical issues, kyphoscoliosis and its impact on respiratory function, and also surgical access. And of course, the management of some of the other features, so the calcium metabolism, which doesn't seem to, most of the adults, isn't a major clinical problem. It's usually abnormal on their bloods, but it's usually not a major clinical issue. So obviously, as a cardiologist, we look after the heart bits, but the cardiologist is often the only health professionals that the patient has contact with in adult life. So they will often have been seen as a child in immunology, endocrinology, community peds, and that all then disappears, and the only thing that's left is a cardiac issue. So, and I think it's fair to say that most GPs have barely heard of the condition, and let alone know what they're really meant to be doing with it. So cardiology does have an advocacy role to play with the patients, aiming to make sure that all their T's are crossed and I's are dotted to make sure that they've got the best care that they can. So we see quite a lot of patients that are already diagnosed. So obviously cardiac condition with 22q11 deletion diagnosed at birth or during childhood. And when they transfer through to adult services, we try to establish a new baseline. So some of them have obviously moved regions. As I say, lots of them have been discharged from paediatric services early in life. So the point of transfer, or when they've got used to us, we usually ask for an updated immunology assessment and an updated endocrine assessment to look at calcium and thyroid metabolism. We ensure learning disability team social work input and benefits assessment are made. And at that point, we re-refer or offer re-referral back to genetics to discuss future childbearing in particular, and we'll talk about that in just a little bit more detail. And we also flag with the GP the need for annual bloods, because we necessarily be seeing them every year, and it's probably a primary care kind of responsibility to take on that screening. We also will assess for other issues of concern, not that we're expert in that area, but obviously ENT, spinal, ophthalmology, etc. And those without a pre-existing diagnosis. So we still see some new diagnoses. Sometimes patients from overseas, and occasionally UK patients who weren't tested as babies. I've sent one off this morning, actually, a fish for 22q in a patient who is 27, diagnosed with an ASD at the age of 16, went to special school, left special school at the age of 16 with no qualifications. She's never worked. She has no learning disabilities team input. She's not got a social worker. She lives with a partner. She's on unemployment support allowance. She's not got PIP. The ASD was diagnosed and was in another centre, and then she moved house, but nobody's ever picked it up, and she's obviously not got capacity to pick those things up and run with it. So she's had a pretty rough trot in terms of her cardiac disease, and also the management of her learning disability has been pretty poor. And she's got nasal speech, fairly typical facies, and an ASD, which is a massive ASD, but it's not really a typical cardiac lesion. But I'd be very surprised if her screening doesn't come back with something. And And that's obviously something that will have been missed, and she's now 27 and missed out on all of that workup that should have been done. The other thing that we do sometimes see is babies, adult UK patients who were tested as babies and everything was said to be normal. And sometimes we're a really high index of suspicion, typical features, and we do request what's fondly known as a recount, which, because of the changes in genetic screening techniques, quite often does actually come up with something, but they're quite interesting as well. And it's interesting how the patient and families respond to a new genetic diagnosis, and obviously we talk to them about it before we test them, but some of the parents of these young adults feel quite relieved when they receive a genetic diagnosis, because up to then they've thought it was something that they did when they were pregnant or something else, and they feel quite relieved that there's something that ties everything together, that ties in the learning disability and the behavioural issues and the the mental health problems. So it can be quite a relief for patients to get that as a diagnosis. And then pregnancy is a one that we do need to talk about. So we have more and more women with complex cardiac disease surviving to reach childbearing years, and of course 22q11 deletion is no barrier to sexual activity. So it's really important that the patients are aware of their own cardiac risk in pregnancy for the ones with cardiac disease, but also their inheritance risk in their own offspring. They also need to be aware and kind of be reminded of the wide variation in the phenotype. So they will often assume that their child, if they do have a child that's affected, will have the same level of functioning as they do. They don't always know, not always aware that that level of functioning in life can be higher or lower than theirs. So we do send them all back for genetic assessment and counselling. Of course, not forgetting about the male patients. It's very easy for people just to think about the women, but also think about the male patients. And then we've now had a few patients that have gone through pre-implant genetic diagnosis. There's one who immediately springs to mind, who functions very well. She works full time. She's married. Very well aware of the impacts of her 22q11 deletion on her own life and her sort of family's life. So she went through pre-implant genetic diagnosis and has a baby who is chromosomally normal and has no congenital heart disease or any other problems. So that's an amazing kind of advance, really, and something that makes the patients very hopeful and optimistic about the future for themselves and for their own families. So that's a great thing, a really happy thing about it. I think, yeah, so